Thank you. It's now my great pleasure to introduce our next speaker, Wendy Preston from the Royal College of Nursing here in London. With over 35 years' experience, Wendy specialises in advanced nursing practice across diverse roles. She holds an MSc in respiratory care and independent nurse prescribing, plus a PG cert in higher education. She is now pursuing a PhD in nursing research with an international focus. After a decade in ward management, Wendy moved to clinical academia, combining advanced nurse practitioner and senior lecturer roles before becoming a consultant nurse. She advocates for legislative change to empower nurses in delivering safe, effective care. And Wendy's going to be talking to us today about advancing human nursing practice within the UK and wider. Thank you, Wendy.
Thank you very much, and thank you for the invitation. I appreciate a very different subject than you've had the rest of the day, but listening to the last presenter, I think we have such a lot of commonality particularly in the language that we use. So thank you there for the introduction. I currently have a portfolio of roles. I'm the Head of Nursing Workforce for the Royal College of Nursing. The Royal College of Nursing is the professional body in the UK for nursing. It's been around well over 100 years, 115 now. And we are also the largest trade union. We have over nearly 600,000 members, so a large amount of members across the United Kingdom. I've been at the RCN now for about 9 years, but prior to that, as I mentioned, I was a full-time consultant nurse, and I've kept an honorary role, and I'll talk a little bit more about that later. And I've got also 2 clinical roles, that honorary consultant nurse role and an advanced nurse practitioner role in primary care, and I'm going to talk about those a little bit more later in my presentation. So before we talk about the UK, I just want to go global. Advanced nursing has been around for many years, about 50 years or so in the USA and parts of Canada. Very much not national, but varies between different states. Across the years, nursing has advanced in very different ways in different settings. So, for example, in Africa, it might be a lot about population health, it might be a lot about rural localities, and there's some fantastic examples in the Caribbean islands where, you know, the advanced nurse might be the only person that delivers any healthcare in that island. And I'll talk about that a little bit later when I talk about the United Kingdom. So quite a lot of differences. So I've been very fortunate to lead a piece of work across Europe for the last 4 or 5 years, and it's now become part of my PhD studies. I'm studying a doctorate of nursing research at King's College London. Very fortunate that my primary supervisor, one of them, has become a baroness because of her nursing expertise, and she's Baroness Anne-Marie Rafferty, very outspoken and knowledgeable around nursing, and it's been fantastic to have an academic to be recognised and to be given a seat in the House of Lords. The work I've been leading for EFN, so just to give it a bit of context, EFN is the European Federation of Nursing Associations. So they've got 36 different countries that are members of EFN. So the RCN is a national nursing association, and we are a member. So a lot of reach. We haven't quite got the whole of the continent of Europe, but quite a big reach across Europe. And we do a lot of work also with World Health Organization Europe so that we can get that sort of wider reach. I've been chairing their advanced practice nursing working group, say, for about 4 or 5 years. The first thing I did was start with a survey to think, what do we mean by advanced? practice nursing. What do we mean? Well, we meant the survey results, and it's been published in an international journal, showed there was a great degree of variability to what do we mean. So what we mean here in the UK, and other countries like Estonia, who have got a very established advanced practice, might be very different to some of the other countries. And whilst we've got legislation in the UK to empower nurses to prescribe independently, when I talk about prescribing across some of the other countries, it's prescribing a dressing. So a big variation. So that then led on to my PhD work, which across, hopefully in the next few years, I will demonstrate a reduction in the variation of advanced nursing practice across the continent. Why is that important? Well, if we've got variation, how can we go forward? And how can we get, say, for example, a common training framework across Europe, but also globally? We do a lot of work with the International Council of Nurses, which is a global organisation, and the Royal College of Nursing is a member of that organisation as well. That brings the national nursing associations together across the world. So I tend to be involved in lots of global work where I'm bringing the European context with the other continents so that we can all work together to try and reduce variation. We've developed a toolkit, so there's an EFN advanced practice toolkit that we've developed. The working group that I lead has got 18 countries involved, and everything we do, we have to get all 36 countries to agree. So if you can imagine, there's a lot of diplomacy that goes on in those meetings twice a year when I'm trying to move everyone in the same direction, where we might be talking about Albania, and I might be talking about Spain, and how can we all agree. But we've had agreement from all 36 countries, so I'm really, really pleased. This slide just summarises briefly a model that we've developed. So first of all, we have to think about the culture and the cultural changes. And if you think about advanced nursing practice, I've been a nurse, say now, over 35 years. When I qualified in 1992, it wasn't a degree. It was very difficult. It was a certificate. And I also, lots and lots of things have changed since then. When I qualified, doctors diagnosed and nurses never did. And that was drummed into us. You're a nurse, you never diagnose. And you'll see later when I talk about my own clinical practice, I diagnose all of the time. So there's been a real big cultural shift, and I've lived and breathed that as being the first advanced nurse in a hospital, and bringing that culture. So what we've done is get that learning from across all of those countries to think about, how do we change culture? How do you do that for a country that has never even thought about advanced practice? And I always say to them, get the doctors together. Get them together, get some doctors who have worked in a country where there is advanced practice, get them to talk to each other. As a nurse, it's never going to land well. But we've made some great progress. What we've also done is thought about the education, the capability. And we've developed a toolkit. So it's got core competencies, so 8 core competencies for those individual nurses. And then 5 principles that we've agreed, which are here, that each country, these are principles for each country to work towards, in the goal that we'll all end up in the same place. And we've developed a roadmap. So you've got if anyone wants to go on the QR code, you can get access. It's free access to the roadmap. I like everything on one page. So how do you start moving? What are the milestones to get there? We're talking about postgraduate education today, so I'm going to focus on that. So it's a minimum of a full master's degree. Now, of course, that can be quite variable. So we've looked at, well, what does it mean in each country? What are their processes? What are their systems? And that's what I've just resurveyed the 36 countries. I'm not published yet, so I'm going to be very careful what I say. but we're moving in the right direction. And some of that variation, it's not actually they've still got a full master's, but some of the detail that sits under what does that mean, has started to improve. There's a real appetite across Europe for a common training framework for nursing, and you need to show commonality. And that's where I'm hoping the work that I'm doing as I publish across my PhD and this work that we're leading across Europe and globally will help to demonstrate that. So I'm hoping at some stage we can do another survey that shows enough commonality across these 5 areas. My big problems are independent nurse prescribing. We've got a good model in the UK, which I'll talk about shortly. But internationally, there's a long way to go. So I've also developed a roadmap on how to develop independent nurse prescribing at a country level. I'm going to bring you back now to the United Kingdom. So as I mentioned earlier, we are the Royal College of Nursing. And believe it or not, after many, many years since Florence Nightingale of nursing being established, and over 100 years of a professional body, we did not have one UK professional framework for nursing. And I've been really privileged to lead that work over the last few years. So first of all, we redefined nursing because it had changed a lot. The previous definition was 20 years old. A lot's changed since then. And then we looked at levels of nursing. So we have in human medicine, not medical, but within all the other allied professionals, we've worked together because you think you've got confusion the public can get very confused. What do all these mean? And we've got absolutely hundreds and hundreds of titles and role titles, which make it very confusing. I'm sure a lot of you who've experienced human medicine will know that. So enhanced, advanced and consultant level is very similar in all the other professions. So if you look at pharmacy, you look at physiotherapy, radiology, we've used that same language. So the next few slides, I'm going to show you some of the difference there is across the 4 pillars of nursing, which is clinical, research, education, leadership. Now, at any time in someone's job plan, they might have a lot of their work that is more clinical, but another time it might be more education or research and leadership. So it varies. Every single job plan will be slightly different depending on their role. I'll have, in one of my later slides, there'll be QR codes for all of this. So what these next 4 slides show you is the difference in the complexity that we're going from when you go from enhanced to advanced to consultant. And this is the clinical pillar. A lot of the language that you're probably very used to. Competencies will often be very similar to than you will see in other professions. There is a difference between the two. So on the clinical, for example, if I was going to have a chest drain inserted, if it was a doctor, or if it was a nurse, or if it's a paramedic who might be doing an advanced role in an emergency department, I want them to have the same level of competence, the same training, the same assessment, and the same standard, because they're putting a chest drain in me. And that's the same we say for nursing. So, and that would usually be in advanced, or you might have a consultant nurse that does that role as well. So we've had a lot of multi-professional discussion and learning as you go through, and you will see advanced nurses in different locations. That example is probably an emergency department, but it could be, say, a respiratory ward or a cardiothoracic unit. And don't be surprised if it is the nurse that's inserting that chest drain if you need to. They'll also teach the medical student, the resident doctors, and they'll also sign them off if they're competent. So we have that multiple profession working, and that goes across all of the pillars. Also, just to give some examples of the types of different roles. So, for example, in education, we might have practice educators, we might have lecturers, associate professors, deans. So they're working at different levels within that pillar. Research has been our difficult one. It's the one that often people don't have much in their job plan. But more and more we're getting researchers coming through. There's a lot more people like myself doing PhDs and leading research. When I was a consultant nurse, a full-time consultant nurse, I brought a piece of research to the trust. And I remember my other consultant, my medical colleagues, we were sitting down discussing this research I'd brought into the trust. And they said, who's going to be the principal investigator? I said, well, I am. And they were like, oh, can you? Of course I can. Well, we've now got a framework that says you can. And I said, what training do I need? A day's training with the National Institute of Research, the NHRI. So I did the one-day course and was principal investigator. We also have different contexts. We might have research nurses, so they might be enhanced, advanced, or consultant. It all depends. And the same with leadership. So, for example, you might have a ward manager, and we haven't got this career framework particularly mapped out yet. But when we're talking about enhanced, we tend to be talking perhaps a ward manager, a unit manager, a bed manager. Advanced might be your matron. Consultant level might be your lead nurse managing a big team. So just a couple of UK examples. I'm not going to go through this one, but just to show that this is UK-wide and we might have different contexts in different places. This particular set of slides looks at where you've got examples of advanced and some guidance. So in Scotland, there's some great examples of island nurses and having often the only clinician on that island being a nurse. In Wales, we've got some fantastic advanced district nurses that lead the care across a whole range of nursing and care homes. So they'll do the daily or weekly rounds, which traditionally the general practitioner, the GP, would have done. Northern Ireland, you've got care homes, again, very similar model where they're going in doing those rounds. And in England, same-day emergency care, which is like going in hospital, but you don't stay in the bed. It's a model I set up in the West Midlands when I was a consultant nurse, like my master's studies led on to developing an SDEC. We have some fantastic examples of advanced nurses leading those services. So, back to my roles. So this is the cart that I work in at the weekend. I'll be there this coming weekend. I work part of a national 111 and it's out of hours general practice service. So I would imagine for those of you that live in the United Kingdom, you will have used at some stage one of these type of services for either yourself or your family. In England, this is the only career and competency framework that we have so far that is across medicine, so medicine and nursing and allied health professionals. It's like I say, a multi-professional rota. When I'm on rota, I'm there as Wendy, advanced nurse, and I'm on with the doctor. I tend to work night shifts, and I'm the lone clinician with my fantastic driver / receptionist for approximately 350,000 people in Warwickshire. Commonly, because we have a lot of issues in workforce and staffing, as you know, in the health system in the UK, but often I can be responsible for 500,000 people. Thankfully, a small amount of people, and it's cradle to grave. I have the authority and the responsibility and the autonomy to do what I need to do. So that's assessment, diagnosis, referral, where everything is audited, exactly the same, whether you're a doctor or a nurse or a paramedic, we have the same audit system. And I've been doing that role now for about 15 years. We don't share our audit results with our medical staff because, but I'm just bringing it together for my PhD work, and actually it's very favourable. And I think because the nurses bring that holistic element to it. We have a great relationship. I've been doing that 15 years. When I started, it was Wendy's here tonight, she's a nurse. Now we're all called clinicians, and we've just achieved my wish. In our new cars, doesn't say doctor on the top anymore, it says clinician. So that was a sort of fantastic thing to achieve. And then my consultant nurse post, as I say, it's honorary now. I tend to sit on an England programme board for respiratory, West Midlands and the hospital, local hospital board. I just wanted to share a little bit of, you mentioned in my introduction, so I won't repeat on the postgraduate education. But I think that's so important. When I started 35 years ago, nursing was not a graduate profession. It is now a graduate profession. It's expected, and the majority of nurses coming through their education now will want to and be or be straight onto a master's programme. I'm actually studying at King's on my PhD with some master's students that have come straight out from university and gone straight onto their master's course because they got such good results, and they are probably going to be the researchers of the future. I did it in a sort of evolving way. I had to do my diploma in the 90s, my degree in the early 2000s, and then obviously my master's. My master's was multi-professional. It was they were doctors, nurses, and other allied health professionals, and we all studied together, which is a fantastic model. It's taken a long time. When I was first consultant nurse, I was reminded, don't forget there's consultant in front of your name, when they wanted me to do lead the ward round on acute medical ward, which is fine. I had the competence and capability to do that. But on other days, don't forget you've got the word nurse in your title. So a lot of struggles. But I think with our standards and the levels that we're going in the right direction. These are a couple of it's very medical journals that we have that I've published in. And I was very pleased just earlier in the year, I think it was, to be asked to write the editorial for some latest guidance on tobacco addiction services for the UK. Just a quick funny on that one there. You all know here, because it's a UK audience, that's a politician, but I use this in an international one. And often I'd say, you might think that's me, the nurse standing dutifully with the doctor, or this is a politician, talking to the patient. But that was same-day emergency care. They were my patients. I was the clinical lead for those services, for that pathway, and had the responsibility. And then finally, at the top, some work that we've done. I think it's fantastic that we work together as Royal Colleges, and that was some work that we did jointly a few years ago on the One Health project, and landed me on the BBC News to talk about the effect of smoking on dogs and cats and other small pets. So finally, I've just popped you a slide with all of the things on our professional framework, which I'm not going to talk about now, but just to see, it's been a lot of work to develop the first ever professional framework for nursing. We've thought about from nursing support workforce, and we've defined those levels of supportive, assistive, registered nurse, enhanced, advanced consultant, and beyond. And we've also brought together all the career frameworks into one place, and we're filling some of the gaps so that you can see what nursing is across the various different specialities and different settings. Our aim is, as we develop, that common language will go through, so they'll all then talk that common language. And then hopefully, with my European work, that will be replicated in all the other countries, and then hopefully at some stage, you might be able to go from one country to another and bring your qualifications to the UK when we have somebody move from one country to another. Thank you very much.
Thank you, Wendy. We've got time for a couple of questions if we have. They're just bringing some microphones. Bear with. And the gentleman on the front as well, please, Debs.
Thank you so much. Actually, it's for us in veterinary medicine, I think UK is a great example. They're showing really well how they're trying to empower the nursing role. But if you would go outside of UK, there is a gray zone, no legislation. Anyone can walk into the clinic and say, I'm a nurse. We're starting to have licensing body and registration. But what it comes to difficult, let's say, is in veterinary medicine, we need to change a mindset where some vets work their whole life without nurses, and they have the title, let's say, of a receptionist. We have to fight with the delegation, where we could maybe win sometimes of diagnosis or making consultation and rely on a team of nurses. I think UK show a great example, but I'm working outside now, so I've seen both. The other question that I would have, because you're kind of leading the way for our profession, which is, it gives me a lot of hope, and I can use your framework to say, let's try to replicate this. For us, it's going to be, the first question would be a huge challenge to try to have an application across European countries. And the other question that I thought was interesting is, do you experience on your clients the term clinicians? For me, can be a bit, let's say, double cut. I think it promotes the nurse and the work they're doing, but on the patient side, they have this confusion sometimes of saying, I'm seeing a clinician, which means I'm seeing a doctor. And this we see more and more in other countries where the nurse kind of delegate and start to diagnose, and it can lead to, let's say, unwanted consequences.
So just answering your second part of your question there, it's less often now, but it's at least every shift I will have someone say, I always answer the door, or if they come into my clinic, because I do both clinic, I do home visits and clinic and telephone. And I always introduce myself, hello, I'm Wendy, I'm an advanced nurse. And then as I often leave or they leave, they say, thank you, doctor. And I just say, don't forget I've got the added value of being a nurse. Because it annoys me when people say I'm just a nurse. I've got the added value of being a nurse. And I think we have to, I say that less now. Clinician is really useful. It's a phrase that is across professions, because if something says physician, I can't do it. The word physician means doctor. So we have to be very careful to not have guidance and things that say physician. It's taken me a long while, especially in England and with NHS England, to change a lot of the language. You might hear the adverts and things on the radio have changed because it used to always say, go and see a doctor. But it takes a long, long time. European, the examples I mentioned there, you have to think baby steps. You know, I won't get the whole 36 countries to be in the same place in 3 or 4 years' time, but I might get 10, 12 countries that are, and you only need 9 countries to get a common training framework in Europe.
There's just one question at the back, and then we'll come to you if that's okay.
Sammy, come on. Thank you. Thank you. That was very interesting to hear about the trajectory of the advanced practitioner role. I just wondered how much, if any, legislative change was needed either in the UK or in some of the other countries that you've worked with in order to support this advanced practitioner roles and different levels.
Yeah, absolutely. So I think we mentioned earlier, I was a senior lecturer for prescribing about 15 or so years ago. Legislation has changed. We've had legislation in the UK for nurse prescribing for, since 1999, sort of. But 2006, the legislation changed that we could have independent prescribing. And that's what we've put on our roadmap. Don't follow the UK in our roundabout way, starting with a few little medicines that you could prescribe. That's not safe. It's safer to have authority and autonomy to prescribe. Nurses prescribe very little according to guidance, and that's what the evidence shows. But we had to do that roundabout way to help with the culture of our, particularly of our medical colleagues. We have still got a couple of laws to change. I'm very pleased with recently, about 3 or 4 years ago, changed the law that stopped only doctors could sign fit notes, so sick notes as they were, and that changed. I was part of the lobbying with the ministers for that. So really pleased. There's 5 professions now, including doctors, that can sign fit notes, so I won't go through them. But there's a couple of laws, mental health law we need to change, but apart from that, we're doing well in the UK.
Thank you. And one final question. Thank you.
Yeah, we in the veterinary profession are very proud to be linked with our Royal College, which covers vets and nurses. You seem to be, by the way you're talking, rather proud of being distancing nursing from doctors. And is that a conscious thing, or is that something that's just come because of short staffing in doctors' profession or whatever? I don't see the veterinary profession coming in that way, but would you like to comment?
I think we've got closer, not further apart. So we work very collaboratively. One of those papers I mentioned was I sit on the Royal College of Physicians group around tobacco control and tobacco addiction advice. That came from there. I think we work very, very closely as Royal Colleges, and some of our curriculums are joint. So when I mentioned about that chest drain example, you know, that's working collaboratively with, I'm a member of the British Thoracic Society, you know, the other guidance around ambulatory pulmonary embolism, I'm one of the authors, and that's the British Thoracic Society. I think we work closer together. It's not about pitching ourselves against doctors, it's about how we work collaboratively. And for some of the career frameworks that I mentioned earlier, some of them are across professions. Because, so for example, respiratory, you know, we work particularly close together because there is a lot of joint competency. When I work in clinical practice out in general practice, I might have my students that sit next to me are registrar GPs, and I'll teach them and I'll sign off their competencies. So we work very, very closely together.
Thank you, Wendy. Thank you very much.